Welcome back to the muscular system. In Lecture 7, we built the anatomy and physiology, the three muscle types, the structural chain down to the sarcomere, and the sliding filament mechanism. Today we look at what goes wrong. 3 parts, the familiar shape. First, pathophysiology, strains, the everyday injury you'll see constantly, and muscular dystrophy, a devastating inherited disease that teaches you how simple single protein matters. Second, diagnostics, range of motion and muscle strength assessment, both skills you will personally perform, plus the labs that support them. Third, pharmacology, muscle relaxants, NSAIDs, and acetaminophen, which are among the most common medications on any chart. When we talk about a strain, picture torn muscle fibers. When we discuss dystrophy, remember that the fiber has a structural protein anchoring it, and imagine what happens when it's missing. When we grade strength, you're measuring how well sarcomeres are pulling. Our 5 outcomes. First, describe muscle strains. Tell a strain apart from a sprain, a distinction students confuse all the time, and grade a strain by severity. Second, explain the pathophysiology of muscular dystrophy and recognize how it presents in a child. Third, describe range of motion assessment and how a goniometer is used, because you'll be holding one. Fourth, apply the 0 to 5 muscle strength grading scale and name the supporting tests: creatine kinase, EMG, biopsy, and genetic testing. And fifth, identify the drug classes used for muscle problems and match the common trade names to their generics. Here are the medical terms you need to know to understand this lesson fully. Take a moment to look them over and pause the video to take notes. Here's the roadmap for today's pathophysiology, and notice that both major conditions do their damage at the level of the muscle fiber. Strains are the everyday injury, muscle or tendon fibers stretched beyond their capacity or torn outright, usually from overuse or a sudden force. You'll see these constantly in primary care, urgent care, and sports medicine. Muscular dystrophy is the opposite in every way. Not an injury, but an inherited disease in which muscle fibers progressively degenerate and are replaced by fat and scar tissue. It's far less common, but it teaches something profound about how a single protein holds a muscle together. And under also common, 3 conditions worth naming because you'll encounter them daily. Cramps, which are sudden involuntary contractions. Tendinitis, inflammation of the tendon where muscle attaches to bone. And disuse atrophy, the wasting that follows immobility, which is exactly the use it or lose it principle from the last lecture, playing out in a patient whose arm has been in a cast. Here's the theme: whether by injury, by genetics, or by neglect, muscle disease is fiber damage. Let's take the 2 main conditions one at a time. Our first condition is the strain, what patients call a pulled muscle. It's a stretch or tear of a muscle or its tendon. The causes are predictable: overuse, a sudden forceful movement, poor conditioning, or skipping the warm-up. The classic scenario is a weekend athlete sprinting after months on the couch and feeling a sharp pull in the hamstring. Signs are pain, muscle spasm, the muscle guards itself by tightening, swelling, weakness, and sometimes bruising as blood leaks from the torn fibers. We grade strains 1 to 3. Grade 1 is a mild stretch with only a few fibers damaged. It hurts, but the muscle works. Grade 2 is a partial tear with more pain, swelling, bruising, and noticeable weakness. Grade 3 is a complete tear with loss of function. The patient cannot use the muscle, and sometimes you can feel a defect. Grade 3 may need surgical repair. Treatment for most strains is RICE, rest, ice, compression, and elevation, followed by a gradual, controlled return to activity. Returning too soon re-injures the healing fibers. Now the card on the right, which is the single most confused pair of words in this course. A strain involves muscle or tendon. And remember from lecture 7, tendons attach muscle to bone. A sprain involves a ligament, which attaches bone to bone. When we say strain, think muscle. When we say sprain, think ligament. Our second condition is muscular dystrophy, actually a group of inherited diseases marked by progressive muscle degeneration and weakness. The most common and most severe childhood form is Duchenne muscular dystrophy, or DMD, and it's the one to know. Here's the pathophysiology, and it's elegant and terrible. Muscle fibers contain a protein called dystrophin, which anchors the internal machinery to the cell membrane and cushions the fiber against the stress of contracting. In Duchenne, a mutation means dystrophin isn't made. So every time the muscle contracts, the fiber tears itself a little. Over years, fibers die and are replaced by fat and scar tissue. Think back to lecture 7. The sarcomeres pull, and without dystrophin, the cell literally comes apart from its own pulling. The dystrophin gene sits on the X chromosome, so DMD is X-linked and affects boys almost exclusively. Mothers are typically unaffected carriers. The card on the right shows how it presents. Weakness appears in early childhood, a waddling gait, walking on the toes, frequent falls. Gower's sign is characteristic. Standing from the floor, the child pushes off the ground and walks their hands up their own legs because the hip and thigh muscles are too weak. The calves look enlarged, but the bulk is fat and scar rather than muscle. And CK, the muscle enzyme, is dramatically elevated, often 10 to 20 times normal, because damaged fibers spill the CK into the blood. There's no cure. Steroids, physical therapy, and supportive care slow the decline, and respiratory and cardiac complications ultimately dominate. Treat these families with the compassion this diagnosis deserves. How do we assess a muscle problem? Two core assessments, and you can perform both. The first is range of motion. Range of motion is simply how far a joint moves in each direction. And remember the distinction from the skeletal module. In active range of motion, the patient moves the joint under their own power. In passive range of motion, you or the provider move it for them. That difference is diagnostic. If a patient can't lift their arm, but you can lift it easily for them, the joint moves fine. The problem is muscle or nerve. If neither of you can move it, the joint itself is restricted. The goniometer, which looks like a protractor with two arms, measures the joint angle in degrees so we can document objectively. Elbow flexion to 110 degrees rather than saying a joint is somewhat limited. Always compare the affected side to the unaffected side. The patient's own opposite limb is the best reference standard there is. Limited motion has several possible causes: pain, swelling, stiffness, or true weakness, and distinguishing them is the provider's job, informed by your careful measurement. The terms on the right are the vocabulary you'll write in the chart: flexion and extension, bending and straightening, abduction and adduction, moving away from and towards the body's midline, rotation, and supination and pronation, turning the palm up and down. And the rule bears repeating: never force a joint and stop if it hurts. The second core assessment is muscle strength, and this scale is worth memorizing because you will document it constantly. It runs 0 to 5. 5 is normal, full range of motion against full resistance. You push and they hold. 4 is full motion against some resistance, but they give way under strong pressure. 3 is full motion against gravity only. They can lift the limb, but it collapses if you press at all. 2 is full motion only when gravity is eliminated, meaning they can slide the limb sideways along the table, but not lift it. 1 is a flicker of contraction you can see or feel, with no actual movement. And 0 is no contraction at all. The logic is a staircase. Can they move at all? If not, feel for a twitch, 0 or 1. Can they move it against gravity? That's 3 or better. Then add resistance to separate 4 from 5. Grade the affected side and the unaffected side and record both. The card on the right holds the supporting tests. CK is the muscle enzyme that spills into blood when fibers are damaged, dramatically elevated in Duchenne muscular dystrophy. EMG records the muscle's electrical activity. Muscle biopsy examines the tissue directly. Genetic testing confirms muscular dystrophy and identifies carriers. An MRI or ultrasound can image a torn muscle when a strain is severe. Now the treatments. 4 classes, and they sort by what they actually do. Muscle relaxants like cyclobenzaprine and methocarbamol ease the painful spasm that accompanies strains and back injuries. Here's the counseling point you'll deliver. They cause significant drowsiness. Warn patients not to drive, not to operate machinery, and not to combine them with alcohol. Many are prescribed at bedtime for exactly this reason. Antispasticity agents, baclofen and tizanidine, are different. They're for spasticity, which is the stiff, tight muscles caused by neurologic disease like multiple sclerosis, cerebral palsy, or spinal cord injury. They're not used for just a pulled hamstring. And a critical safety note, baclofen must never be stopped abruptly because sudden withdrawal can cause severe rebound spasticity and even seizures. NSAIDs, which are nonsteroidal anti-inflammatory drugs like ibuprofen and naproxen, reduce both pain and inflammation. Their main downside is stomach irritation, ulcers, and bleeding, so we teach patients to take them with food. They also affect the kidneys. And acetaminophen relieves pain and fever, but does not reduce inflammation, so it isn't an NSAID. Its danger is different. Too much can cause liver damage. Patients get into trouble by combining it with cold medicines that already contain it. Teach them to read labels and respect the maximum daily dose. Here is the medication table for the muscular system. Recognize these on a chart and know each category that each belongs to. The first 2 are muscle relaxants, Flexeril, which is cyclobenzaprine, and Robaxin, which is methocarbamol. Both ease spasm, both cause drowsiness. The next 2 are antispasticity agents, Leorisol, which is baclofen, and Xanaflex, which is tizanidine, used for neurologic spasticity, not for a simple strain. Then 2 NSAIDs most people recognize, Advil, which is ibuprofen, and Aleve, which is naproxen. Both relieve pain and inflammation. And Tylenol, which is acetaminophen, a pain and fever reliever that is not an anti-inflammatory. The bar at the bottom collects the 3 counseling points you'll repeat for the rest of your MA career. Muscle relaxants cause drowsiness, so no driving and no alcohol. NSAIDs should be taken with food to protect the stomach. And acetaminophen must not exceed the maximum daily dose because the liver injury it causes can be fatal. And patients routinely double dose without realizing that their cold medicine already contains it. One practical note at the top. Each drug appears under one representative brand, but most come as generics and under other brand names. Knowing both names lets you reconcile a medication list accurately. And now our summary. 1. A strain is a torn muscle or tendon. A sprain is a torn ligament. Strains are graded 1 through 3, and most are treated with RICE, rest, ice, compression, elevation. 2. Muscular dystrophy is an inherited loss of dystrophin, the protein anchoring muscle fibers. Duchenne is X-linked, affects boys almost exclusively, and shows very high creatine kinase or CK. 3. Gower's sign, walking the hands up the legs to stand, along with a waddling gait and enlarged looking calves are the classic signs of Duchenne. 4. Range of motion is measured with a goniometer in degrees, and you always compare the affected side with the unaffected side. 5. Muscle strength is graded 0 to 5. 5 is normal. 3 is full motion against gravity only. 0 is no contraction. And 6, the drug classes. Muscle relaxants, which cause drowsiness. Antispasticity agents like baclofen, which is never stopped abruptly. NSAIDs taken with food. And acetaminophen, where we watch for liver health. In Lecture 9, we finished the muscle module with your role. Ambulation assistance, safety, and positioning support during exams. Here are the references for this lecture.